I'm David Pryor, and thank you all very much for joining the call. And Caroline, thank you very much for organising it all. We're in the same office at NHS England, by the way. So look, we've been talking about data for at least, well, since ever I came to NHS England, which is 2 years ago now. And I think that what COVID has done is to demonstrate once and for all just how important it is and how powerful it can be. Whether that's through drug discovery, clinical trials, managing the system, procurement, outcome-based pricing, whatever aspect of healthcare, data is going to be a very fundamental part of it. So I think this meeting is very important as we run up to the comprehensive spending review in November. We need to put together a very powerful case to government to curate the data better than we have it at the moment, and structure the data better than we have it at the moment. So I see this meeting as being a very important part of that sort of build-up, if you like, to the autumn. So I'm now going to hand over to Caroline, who's going to introduce the day.
Brilliant, thank you.
Caroline.
Thank you. It's lovely to see you all. So, and thank you so much for joining today. We're going to have a fun hour and a half together. So we're going to cover a lot of ground. It's going to be far too much. We're going to try and squeeze into far too short a time. So I apologise in advance for all the conversations we're going to cut off and not perhaps get through as much as we'd want to in that. But what we wanted to do today was really to spend time, brought together a group of people from across the different areas, so people who work with health data in different research capacities, lots of expertise on the call, and lots of experience. So just really wanted to kind of draw together all of you to kind of test out some of the ideas, test out thinking, see what we've all learned over the last 4 or 5 months of having gone through the COVID experience, so that we really set ourselves up well going ahead. This is very much an early conversation. There'll be lots of conversations coming after this, so but really just wanted to kind of get the ball rolling on it. So Lindsay, if you wouldn't mind sharing slides, what I'm going to do is give a little bit of an overview first of all, and then what we'll do is go into introductions of everyone, so you know who everyone else is on the call. And through that, I'll be asking you to answer the first question as we do the introductions. So you can be bearing that in mind as I do my introduction on the slides on that. So Lindsay, if you wouldn't mind putting the slides up, that'd be great. Lovely. So we can go on to the first slide. So if we, so the plan today, we're just going to give a brief overview. We're then going to go into 3 questions which we shared in advance. The first question we're going to talk through as introductions. Second question, we're actually going to go into a breakout group, so we actually have a bit of chance to go into a bit more depth on it. And then third, we'll have a discussion in plenary before going into the wrap up. Click on to the next one, Lindsay. So objectives today really are to share the lessons and insights we've had all together from health data research during COVID period, making sure we then build on these lessons and see what opportunities this means for health data science going forward, and to really get some practical things that we need to do now to make sure we actually meet those opportunities. Through the conversation, we're going to be talking about the whole of the UK, so wanting to consider England, Northern Ireland, Scotland and Wales, wanting to be considering actually how we work on behalf of the UK, so rather than institute-specific conversations, much more on kind of what we can do collectively across the UK. And the aim will be to use the information from today to actually feed into data and connectivity strategy which is being developed for SAGE, and also into a systems leaders roundtable which has been set up in September. So and through all of this, we'll be making this available on our website so that anyone can see the conversation going afterwards on there. Next slide, please. One of the things, and we shared this in the pre-reading, was that I think one of the messages that's come out of COVID is that health data science has really helped draw out, and this is a collection of 10 different insights that have come out about COVID that we now know because of health data science. So it really does show the breadth and the kind of the range of value that comes from health data science and from health and cross-sectoral data on that. And click through. And when we, so one of the things that HDR UK was doing through the COVID period was working with SAGE and collecting the questions and prioritization, so we could actually make sure we got the right data and research happening to support the COVID response. When we look back over it, something like about 110 research questions that came through that process. When we look through them and you distill them down, we came to broadly 8 core questions that really needed answers to quickly. And hopefully these will be quite familiar to you and the types of things that have been worked worked on here, be it around risk and stratification, the spread of disease, who's susceptible, who's vulnerable, what's causing the disease, what the different, the impacts on provision, on trials, and then also on survivorship. So this broad kind of collection of questions then became and therefore, when you look forward to what's needed in the next wave and going forward into future pandemics and also to other diseases, these are actually, when you look at them, broadly the same questions you're going to need to be able to answer, and therefore similar data sets are going to be required in that. If we click through to the next page. So when you're taking those questions and actually working through them, it's great to see Frankie on the line from ONS and working together on this. We kind of distilled, and this was the first step, stab at kind of the priority data sets that you'd need to have in place in trusted research environments that you can link together to be able to work through. And you can see it's a long list, but actually it's a fairly finite list of things that actually make a huge difference, so we can have these linked together and to be able to work on them. Click on the next one. And then we've taken that kind of concept of working, so in that bottom left-hand corner of this triangle, of actually getting to a priority set of research questions. Then if you go up to the top in the green, saying that actually that means if we can prioritize those questions, these are the priority data sets you'd want to do. So can we bring together the kind of alliance, the existing alliance, the existing trusted research environments and infrastructure that's set in place? Can we make that data accessible through streamlined access processes? Can we use the gateway that's been established to make that discoverable and make the linkages happen there, filling in some of the gaps that exist in the data sets? And if we go onto the blue corner, then actually can we also put in place and some of the services that got established through the COVID period, can they be scaled up to be able to be up and running in a sustainable way, addressing also some of the gaps in some of the services. And then the orange piece, I think one of the really interesting insights that came out through the COVID period was how effective the patient and public engagement has been in this period, and really how important that has been to have that integrated right in at the start, and how speedily that could be done, and the quality of work that came out as a result of that I think was particularly powerful on there. So by bringing these three parts together, the questions, the data, the public engagement and the services, can we actually establish a way of working as we go into the next stage of COVID that really means we're in a robust and responsive position. We click to the next one. The final slide just really want to take through on this is then broadly, if we look at this is kind of working with Patrick Vallance and the SAGE team, thinking through of the next periods of time, what we're wanting to have in place then is having those pieces, getting them established, getting the trustworthy access set up, then scaling that up so that we can be confident that a large number of researchers can be accessing in a trustworthy, safe way, doing the analysis in the trusted research environments, and then gradually building up to a more federated model where we can actually see the integration and links between the different trusted research environments, so we can actually be confident that we can be doing research at scale in the UK to really get to the answers that are needed to support response to COVID and beyond. So that's, if we click onto the next slide, Lindsay, so thank you. So what, in terms of today then, that's just a very brief overview of some of the thinking that's been going on coming up to today. What we wanted to do today is we brought you all together because we think you've all got great opinions and will have really interesting thoughts, and you'll have differences in opinions, which is fantastic as well. So in that case, we wanted to make sure we hear from everyone. We've created a Google Doc so that we can capture things and using it like a flip chart during the discussion. So please do, when we go into the breakout rooms, there'll be a facilitator who'll be adding things in there, but you can also have that open and be accessing and adding things in as we go through. So we obviously won't be able to cover everything to you today, but there are thoughts and things you want to make sure we put in there. Just all the good housekeeping things in terms of please can you just be on mute when you're not speaking, use the chat function if you've got questions, or raise your hand to ask questions. If we've not seen you, yes, try a few different routes and I'm sure someone will make sure we cover that. It's all being recorded, so, and it'll be made available on our website for the plenary discussion. And we're also going to be using breakouts for the second discussion, and that's going to give us a chance to have a little bit more of an in-depth conversation. If you have any problems at any point, Lindsay's on hand to help us out with that. And so hopefully that will be good enough to get us going on that. So on that note, I think, Lindsay, that's the final slide, isn't it? Great, thank you. So to get us started on that, hopefully that's given you a good overview of where we're trying to go to today. We've got, wanted to go around the table and really ask each of you, and spending no more than 1 minute each because we've quite a few to get through on that, but I just wanted to ask you really the first question in terms of, well, first of all, if you could introduce yourself and say where you're from, and then tell, in terms of relation to health data science, what's one lesson have you had from COVID-19 that you think would be useful to share? So it's a rather big question to distill into a short bit. And I am going to, so apologies, it's going to be a bit of a, yes, lucky you as you get called out. I'm going to go in order of what I've got on the list in front of me. So Ami, over to you to open us off.
Hi everybody, I'm Ami Banerjee. I'm a cardiologist and data scientist at University College London, and I also work at Barts as well. And I would say that my my most pressing lesson would be that although we focus on our data assets and how we have to mobilize them, they're no use if we can't bring them close to the questions from policymakers and clinicians. And actually, some of that can be done with relatively simple data. So it's not that you need really advanced data or always really advanced data analytics to answer the most pressing questions. So we did that to look at the most vulnerable people early on in March to use government guidance for high risk and extremely vulnerable people to try to better risk stratify, and that's using existing primary care data sets. Thank you.
Thanks, Ami. On to Laura. Laura Bickdale.
Hi,
Laura.
yes, hi, I'm Laura Bickdyke from the Office for Life Sciences. I work in the data team. I think my biggest reflection, and I think partly this is because I was seconded off to the testing program for 3 months and then kind of came back to the data space, but just reflecting on how much activity has happened so quickly, and part of that being kind of the COPE notices and opening up data access, but also part of it just being kind of urgency and ways of working. So just really impressed by the amount of activity that's happened in this space.
Thanks, Laura. On to Phil Booth.
Hi there, I'm Phil Booth. I coordinate Med Confidential. We seek to ensure that every use of patients and service users' data is consensual, safe and transparent. And I guess the thing that we've learned from COVID is that saying you're going to be transparent is not the same as being transparent.
Very succinct. Thank you, Phil, for that. Lindsay. Lindsay.
Hi, apologies. I'm Lindsay Cockcroft. I'm the Executive Assistant at HDR UK, and one of the major things I've learned is that there's a need to prioritize well-conducted studies rather than, larger well-conducted studies rather than smaller studies.
Thanks, Lindsay. Gary.
Hello, everybody. I'm from the Office for Life Sciences. My big learning so far, and this is easy to say with hindsight, but I think would be giving us benefits now, is we should think about using research from the very start. So like Laura, I was embedded in the test and trace program. We have access to some of that, so we can utilize it for some purposes. But I think there's an opportunity to simplify and harness the potential of research through the delivery of some of those programs if we can get the data and the information capture correct from the beginning.
Fantastic. Thanks, Gary. On to Rebecca.
Hi, everyone. I'm Rebecca, and I'm the Director of Data and Quality Improvement at the Cystic Fibrosis Trust. And in terms of lessons, I think we haven't suddenly figured out that health data exists and can tell us cool stuff quickly. But I think because of COVID, we've learned how to tap into that data much more effectively using truly multidisciplinary and also multinational research collaborations, because we're no longer so hampered by geography and a feeling that we all need to be able to meet face to face to tackle a problem. And I think that's also been really helped by the fact that I think teams feel like they've got a very clear, well crystallized mission, and it always helps to have people maybe slightly bored going stir crazy at home.
Good advantage to that. Thanks, Rebecca. On to Spiros.
Hi, my name is Spiros Donaxis. I'm a computer scientist by background. I'm a professor at UCL, at the Institute of Health Informatics, and a a research fellow at the Alan Turing Institute. And I guess my biggest learning is that it's still shockingly hard to access information from secondary care providers like hospitals beyond what's available in coded sort of claims data. So anything related to tests, admission, discharges, medication, and things like that is still extremely hard to access at scale. And that most people are not aware that that is actually very hard.
Thanks, Veros. Ben Goldacre.
Oh, hi. My name's Ben. I run the Data Lab in Oxford, and we're a mixed team of researchers, software developers and clinicians, and we've built Open Safely during COVID, which is a fully open source, highly secure analytics environment covering 23 million patients' full pseudonymized primary care data. So I feel like I've been to a lot of meetings like this over the years, and the one big insight from COVID is we just need a ruthless focus on delivery. So we've got to be cautious about too much discussion. I think we've got to look at where the money's gone, look at who's shipped and who hasn't, look at the barriers to delivery, have a frank discussion about them and about overcoming them. And then we've got to disinvest in the organizations that block, and we've got to back the people who ship with open competitive funding for people with a track record of delivery on health data research infrastructure.
Thanks, Ben. On to Ian Hall.
Hi, yes, I think the only chess physician on the call here, but I'm here representing NIHR today. So I guess my reflection will therefore be a clinical one, although I've got things to say about the other things as well. And that would be that locally, without having very rapid access to data within sort of a 2-day process, which historically would have taken us 6 months to get hold of, we would have been unable to plan our critical care capacity. And that had major ramifications for non-COVID work. So we were able to do more cancer work than almost every other hospital in the country because we knew exactly what our planned critical care capacity would be, which enabled us to keep other things going. And that was only due to the ability to access data more rapidly than usually would be the case.
Great, thanks, Ian. Gillian.
Hi, good afternoon. I'm Gillian Hastings-Ward. I'm a lay member on the HDR UK using the delivery group advising the exec. I'm also the chair of the participant panel at Genomics England. And my third hat is that I'm an access review committee member at the Genomics England. So we make decisions about who gets to look at their data set in particular. And I think that one of the things I've learned during the COVID period has been that patients seem quite willing to share their data if they can recognise particularly where it's going and what it's going to be used for. And I think in this time of national crisis, people have been perhaps more willing than they might normally be to donate their data for scientific research.
Thanks, Gillian. On to Matt Hurls.
Hi, I'm Matt Hurls. I'm a human geneticist from the Sanger Institute. I guess my learnings would be that it's critically important to align molecular data with the health and social data, and sometimes that molecular data doesn't come from government; it comes from researchers, and that creates certain challenges. The example would be the viral genome sequences and informing how the virus entered the country. And I guess the second point would be that in the genetic space in which I operate, the international coordination of that research is critically important to get to this kind of sample sizes to get actionable insights. And so we tend to have lots of national discussions, but we need to be mindful on that research domain of the international connections as well.
Thanks, Matt. Emily Jeffson.
Hey everyone, I'll turn on my video as well. Sorry, I hadn't realised that wasn't. Hi everyone, I'm Professor of Health Data Science at the University of Dundee. One of the main learnings I had was quite what a horrible disease COVID is, as myself and the rest of the family all got it right at the very beginning and were properly wiped out for about 6 weeks, feeling pretty rubbish, I have to say. In terms of then sort of trying to come back and find out what had happened in those 6 weeks while I was off, I suppose I learned quite how fundamental it is to get the health data science infrastructures and things in place. We've been trying to do this for many years, and really pushing to try and do it, but until you have this major focus showing quite what a problem it is when you don't have those infrastructures in place, we can't actually move forward. So hopefully there will now be enough funding and focus on this to actually get this UK-wide and scalable. Thanks.
Thanks, Emily, and glad to have you back and well with us on that. On to Anne John.
Hi, I'm a professor of public health and psychiatry in Swansea at the Sale Data Bank, so part of HDR UK, but also lead the translational research collaboration for the MAHR one for mental health, the informatics work stream. And I guess in some ways we've been really privileged because in Wales we had existing infrastructure, but still COVID allowed us, so lots of blockages in terms of accessing data quickly, and then certain data sets that we couldn't access. All those barriers fell away quite quickly with the focus. I think because we had the existing infrastructure, it's allowed us to work very closely with government, which means we're both doing research but also answering directly questions from Welsh Government fed through SAGE often. And I guess the opportunity is that across the UK, if we can sort out the access issues in other places, the idea of federated analyses that will both be at scale but possibly natural experiments where nations diverge is huge.
Thanks, Anne. On Ben Johnson.
Hi everyone. I'm a member of the Public Advisory Board at HDR UK and also a lay member, like Gillian, of the Using the Data delivery group also at HDR UK. And in my day job, I run engagement programs for an academic publisher. In terms of what we've learned, I think we've learned a lot about who's at risk of catching the virus and at risk of severe disease, but not necessarily why these people are at risk or how to protect them. So I think there's a gap there between the science and policy. I think we've also learned, on a more positive note, that patient and public involvement, PPIE, can be done quickly and can be done nimbly, even during a public health emergency. And I would say a minority of researchers are doing this at the moment, but those that are doing it well, and it's clearly improved the quality of research.
Thanks, Ben. On to Indra.
Hi everyone, I'm Indra. I'm the Director of AI at the NHSX, studying at the AI Lab. My key learning from the last 4 months would probably be really clear on what is the ask. People always say, oh, can I have the data? But it's really unclear sometimes what's the problem or the ask they're trying to solve. Not a new thing, but it's become really evident over the last 4 months when people wanted lots of data, but it wasn't always clear why.
Thanks, Indra. Frankie.
Hi, I'm Frankie Kay. I work at the Office for National Statistics and look after data capability, which covers technology, methodology, data and data science campus. I think in terms of the takeaway, I think it's been that actually all the data that we needed in order to answer the questions that we all have is somewhere, and it is getting hold of it. And whilst I've seen improvements on that, I still feel that it's too hard, it takes too long, and in particular if you want to link different data sets together to get that really sort of cross socio-economic view, trying to bring all that together in one place to do that is still more difficult than I think it needs to be, despite some improvements that we've seen.
Thanks, Frankie. Emily Lawson.
Thanks, Caroline. I've been struggling as we've gone through to figure out how not to repeat the points that people have already made, and I can only think that Chris Wigley's going to have to be really, really creative looking at how you're your list. But so let me have a go. I had 3 things written down, and versions of them have all been said by other people, so I'm going to try and make a link between them. And I think what we've learned is that the dichotomies have been extremely challenging, and the answer for all of us now is to try and find somewhere in the middle, or try and find the best of both. And the 3 tensions that other people have referred to One is the tension between the need for a commercial return and the essential public good of what a lot of people were trying to do here, and how to find the right balance between those. Next tension is between the kind of systems and rules and legal position that we needed to adhere to, and the extent to which some of those were just broken in an attempt to get through something in an emergency. And again, neither position being completely the right one. And the third is between sort of allowing that brilliant amount of energy and, you know, the crowdsourcing approach to there's just energy here, or there's just somebody with a brilliant approach, let them crack on with it. And the need to keep that focused on a limited number of critical problems in order to actually solve the problem, rather than just have a scattergun approach and studies that keep contradicting each other because, as Indy said, they're not perhaps focused enough. So I think what particularly I'm thinking about is how, back to the pragmatic point, how do we move forward having learned those lessons while keeping all of those things in balance?
Thanks, Emily. Cecilia.
Hey everyone, my name is Cecilia. I'm a professor at the Big Data Institute at Oxford University. I'm also the co-chair of the International Common Disease Alliance, or ICDA. I think my last 4 months have at least partly been spent on working with the International Host Genetics Initiative for COVID, where the UK Biobank is a proud and important part, also together with other biobanks in the UK. It has pointed to the importance of almost real-time clinical data being connected with molecular data. It has actually delivered robust genetic association with COVID severity, which is really exciting. So on chromosome 3, there is a locus containing a slew of cytokine genes. And it has also helped us disproving one locus in the blood type region that has been heavily debated. So I think, again, large, well-powered studies connecting molecular data with clinical data, national close collaboration across disciplines, but also with international collaborators to achieve robust, high-quality findings with a focus on delivery quality paired with transparency and communication is sort of what I think is really key here.
Thanks, Cecilia. Sindhuja.
Hi everyone, I'm Sindhuja, the Patient and Public Involvement Officer at HDR UK. And I think one of the key things that I've learned from COVID-19 is that there are lots of self-reported trackers and apps that patients and the public are using, which adds a lot of really valuable data. So it's about how can we kind of collate all of those and make sure that they are used in the different research as well.
Thanks, Sindhuja. Anne-Marie.
Hi everybody, I'm Anne-Marie Naylor. I'm Director of Policy and Strategy at Future Care Capital. We span both health and social care, so I'll take a liberty, if I may, and make one point about each. So in terms of learning, I think we've learned in a most terrible way and tragic way that we have a massive asymmetry in terms of the data infrastructure underpinning how we access and make use of data in relation to social care as compared to the health service, even though we've had to take massive leaps in a very short space of time around health. And that's obviously had the consequences we've seen. But I think I would stress that those blockages and barriers that we think we've overcome in relation to health have by no means been overcome in relation to social care in the last 3 or 4 months. And we're now facing the winter. So I think that's quite an urgent kind of fix that needs to, and key steps need to be taken there. And I think from a health perspective, we've come at this in a number of different angles, but we've worked in particular with University of Oxford and NCME to try and pitch in to help with the setup of NCCID and the ethical frameworks around that. What we've seen is in particular that we've got terrific copy notices, as it were, for the short term that have been introduced to help us access health data in a better way. But we've had less success, I think, again, in relation to reaching into providers and other organisations in the broadest sense to understand health and care using non-NHS data. So I think in terms of the national data strategy, we need to think about how we're going to perhaps reach into that. And just to give everyone a flavour, we've got a detailed survey data that we undertook 10 days ago with Ipsos Mori that's not yet in the public domain, but there the public are very supportive of reaching into social care providers to take data from them in order to inform the pandemic handling over the next few months.
Thanks, Anne-Marie. Catherine Pollard.
Hi everyone, I'm Catherine. I'm the Director of Centre Expertise at NHSX. I've been seconded into NHSX's Vulnerable, Isolated and Social Care cell for the duration of COVID. So I'm going to echo Anne-Marie's point and say that actually we need to get the majority of social care providers off using paper or indeed not recording anything, so that we have some data on which we can do any type of research or operational planning. Both for home care and in care homes. I think that's a major priority. And then secondly, I've been organising our mutual aid in Cambridge. And one of the things, this is a very operational problem rather than a research one, but the disconnect between what the Cabinet Office was doing with the shielding population and what was then the queries that were raised locally to the council when they didn't have the list of who was on the shielding list and needed the GPs at that point, I think means that it kind of goes back to Phil's point around transparency and making sure that those who are going to be caring for the populations have got the information around them so that they can address questions as they come up. So that national local balance I think needs to be considered quite carefully.
Thanks, Catherine. Jem Rashbash. Jem on the line? No? Jerry.
So I'm Jerry Riley. I'm Chief Technology Officer at Health Data Research UK. So for me, I think one of the key learnings was we just weren't well enough prepared. Some groups moved at speed with robustness, showing that data access doesn't need to take months, and in a pandemic we can't afford it to. But that we can move faster with collaboration, but also we do have to keep in sight and in mind at all times the public perspective and the public trust. We need to be planning for the next pandemic now. We need to be making this as much part of our DNA, as part of our embedded practice, as disaster recovery is in other industries. So we need to plan and test our plans for secure data access at speed, but also making sure that that is also always with public trust. So we need to be better prepared for next time around.
Thanks, Jerry. Liz Sapie.
Hi, I'm a respiratory physician. You're not the only one, Ian, and also work in acute medicine at the Queen Elizabeth Hospital and was patient-facing during the pandemic. I'm also the director of Pioneer, the HDR UK hub in acute care. Lots of good learnings. It's always quite difficult to go near the end, but I think NHS trusts, be they community, ambulance or hospital providers, want to improve outcomes through the use of their data. They generally want to share that data, but they need support to improve the quality, the completeness, and the accessibility of that data for research and innovation purposes, as well as meeting their national reporting requirements. Hospitals and trusts which have both digital maturity and critically understand the back end of their system can do that, but they remain in the minority. So certainly there needs to be work done to improve the digital maturity of our trusts to make that data more accessible. Thank you.
Thanks, Liz. David Seymour.
Yeah, hi there, David Seymour, Partnership Director at Health Data Research UK and lead on the UK Health Data Research Alliance. During the COVID piece, I've been, I suppose, privileged in many ways to be working on the accelerated access stream of our sort of strategy and response, which has enabled me to sort of work closely with the sort of across the 4 nations and be able to see how those things have developed. And I think my overall learning comes out of that and has already been in many ways picked up, but I think it's worth reiterating, and that's the importance of existing infrastructure, relationships and processes. And we see how, you know, as I think Anne described, how well Wales and the Sale Data Bank were able to respond, both in terms of their connectivity to sort of government and policy, but also their ability to onboard new data sets. So very quickly being able to move to make the symptom study tracker app data more widely accessible and available. In contrast, I think again it picks up Anne-Marie's point, obviously the social care situation is an absolute sort of disaster and very much, you know, partly related to the fact that that infrastructure just isn't there. The ways and means of accessing that data isn't there. And so that's clearly something we've got to address, but also then picking up Frankie's point, where those linkages don't exist already, it's still really, really, really difficult, slow and time consuming. and energy sapping to actually get access to those linked data sets.
Thanks, David. Richard Talbot. Richard?
Hi there. Hi, Caroline. It's Richard Talbot. I'm the Chief Executive of the ABPI, which is the Pharma Industries Trade Association in the UK. So for me, it's the power of national leadership and coordination, particularly in getting recovery trial going. And I think you only have to look at how that whole achievement has been reported by leaders, clinical leaders in the US, to see how so much better we've done here than anywhere else. And there is a real prize to getting it right in the UK. Second thing I'd just say, if I may, I think the depth of collaboration between the commercial and academic sectors, I think, is hugely variable across companies. And that is definitely a learning for us within the industry, and is something I'm looking to take up with companies very soon.
Thanks, Richard. Matt Whitty?
Hi, I'm Matt Whitty. I'm the Director of Innovation, Research and Life Sciences and the Interim Chief Exec of the Accelerated Access Collaborative. Can you hear me?
We can, yeah. Thanks, Matt.
Well, my screen is just there, just frozen. Yeah, I think the key thing that that I take away is I think we need to shout about why we need to get better about data sharing. I really think that why it needs to be more clearly emphasised, alongside how it can benefit patients and how this can be done in a way that protects privacy. And I think all of that needs to be done in a way that a non-data scientist can understand. And I think if we kind of articulate that, that will help address a lot of the issues around sort of the speed at which organisations can share data.
Fantastic, thanks, Matt. Chris has the unenviable task. Chris Wrigley, sorry.
But not a Whitty.
I'm just giving you another role there, Chris.
I do quite often get emails from him. I guess maybe I would try and draw together a couple of points. If what we're trying to do is link research and clinical delivery, I think that's one of the things that worked really well through this time. And one of the really helpful pieces coming out of this for me is that we've laid down some case law. We've achieved things at speed that have shown that this is possible, whether that's in the kind of correlations that were coming out of Ben Goldacre's work and others, the kind of predictive analytics that we saw from the Van der Schaal Lab and NHSD and Public Health England. We touched on the recovery trials, and also critically this point that ethics and engagement can be done well and fast. Doing things right doesn't mean that we have to do them slowly. Equally, doing things fast doesn't mean we have to do them badly. And so being able to link the research agenda and the actual delivery agenda to the work that like Indra and Emily and others have been leading there, absolutely critical. So if I look forward, I think that case law allows us to highlight a few things that need to be true to sustain this momentum into either the next phase of the COVID work or beyond. I think I would massively echo Indra's point. And sorry, I didn't introduce myself. So I'm the Chief Exec at Genomics England, but did a secondment for 2 months to support Matthew on data and worked really closely with Indra, Emily and others on this. Indra's point about clear questions and therefore tight scope being a critical enabler to move fast, I think is absolutely right. And there have been a lot of these meetings about data and health data and what do we do about them. Working back from tight questions and use cases, I think, unlocks a lot of the other things that otherwise bedevil us with sort of, let's just throw all the data together. One of the critical enablers through the COVID phase has been the emergency regulations, right, the COPI regulations. That's not a sustainable way of doing business. And so I think we need to replace the urgency and emergency regulations of the last few months with urgency and sustainable regulations and structures that allow us to get away from kind of computer says no or moving really slowly, but in a sustainable way. And I think the only way we do that is to bring the kind of confidence that we can do this right to that debate. And I think it's the confidence to protect the right things in terms of participants and doing the right thing. And Gillian and others are really strong on this, but also to Phil Booth's point, to have the confidence to be transparent, because what we're doing is the right stuff. And frankly, if it's not the right stuff, sunshine is the best disinfectant, right? You know, we should have the courage of our convictions that either we think we're doing the right stuff and we should be clear about it, or we should have the courage to be clear about what we're doing and be challenged on it. But we have to lead that public debate, and we have to. The only way we can lead the public debate meaningfully is to have the confidence in focusing on the right questions and doing it in the right way, to then bring people with us, so that we're not trying to hide anything and we're not therefore paranoid about it and saying no to the wrong stuff, because there's equally a risk of having a cottage industry of saying no to stuff just because that's, you know, that's perceived to reduce risk. Anyway, so I think that we can take a lot from the case law that's been laid down in the last few months into a more sustainable structure to keep that speed and momentum looking forward.
That's it. Thanks, Chris. I think I've gone through the list, but I can't see everyone on the screen. So is there anyone I haven't asked yet?
Yeah.
Hello. Hi, Chris. Sorry.
Hi, I'm Chief of Staff at GEL. So I have just coming on Chris Wigley's coattails, as it were.
Very welcome, Chris. Hello.
I wouldn't add anything to anyone else has said. I think it's obviously everyone's gone and it's even worse than going after Chris. But I would just say that given what the UK life sciences industry has kind of shown recently, going back to your slide, which says this will require substantial funding, I think if there's ever a time when some funding should go towards this, in terms of when we're looking forward to the future of the economy, this is probably the right time for it.
Thanks, Chris. And I've just seen also Rona. Rona, you're very welcome. Do you want to say yours as well?
Hi, yes, sorry. I'm currently seconded to the Lighthouse Lab here in Glasgow, so I wasn't sure I was going to be able to make it. But yeah, so to introduce myself, I'm an HDR UK fellow here in Glasgow. The only COVID data I've actually seen and had a chance to play with is the UK Biobank data. And I think it is fantastic how quickly it was possible to get that data. However, we are severely limited about what we can do with the data because of the way it was tested. And that is impacting on why we don't know who got.
You're just gone on mute, Rona.
Sorry. So I think that impacts what we can learn from it because of the way the testing was, at least initially, carried out and prioritized. So if we are aiming to plan for the next pandemic, that should really be taken into account.
Fantastic. Thanks, Rona. Anyone else? Is that everybody covered on there? Great. Well, thank you very much. I think you can see from the breadth of, I just got the list of things in here. You can probably see it also in the Google note. We've covered a huge amount just in that kind of whiz through in 25 minutes or so on there. So we can see the kind of breadth of issues that, and the enormity of what we've learned over this period and what we want to be able to build on from here. I'm not going to draw out anything particular in there, but I've got all the lists and things in there. What I'm going to do is actually take us on to the next question, which is actually, as we, and please do, you can see the Google note, please do add things in there if you want to add on. Thank you so much, Sindhuja, for writing them as we've been going through. But if others want to add in further thoughts, you're very welcome to do that live on that. So if I take us on to the second question, which is, if we can build on all of those lessons, what are the opportunities we really want to be focusing on for the next period of time? So for health data science over the 5 years ahead. Lindsay, if you wouldn't mind sharing the slides. You'll have seen that we did an online kind of asking people to contribute thoughts and views in advance. And you can see on the slide, if you can pop onto question 2, onto the next one. You can see the sorts of things that came out on the survey on there. So there was a kind of breadth of different aspects in terms of people had ideas of how to kind of retain and build on the infrastructures that are already in place, how to build on the collaborative ethos, how to look at how can we be using some of the participatory information that was being collated, running studies across different areas, how can we be looking at the kind of international leading aspect on it, and creating greater, stronger links between different areas such as PHE and the research community. So there's a number of ideas people came up with on the survey. But what I wanted to do is to give you a chance to spend time in a breakout group. So you've been assigned each to a breakout room to have a bit more in-depth conversation over the next kind of 15 minutes or so. And then we'll play that back into the group and see what kind of insights and things come out as to where really the focus should be based on the lessons we've had so far. So sorry, that was a rather breakneck speed through that conversation. I'm sure it looks like from the writing, Sanjuji did a lot better than I did on the kind of going through. I'm going to start with group 2, which is what we just go through and just see what sorts of things were coming out of that conversation, and perhaps just a kind of we'll open then into question 3, into more open conversation from there. So Sanjuji, do you want to give us a kind of some of the highlights from your group?
Absolutely, and everyone please feel free to kind of button in if I didn't quite capture it. So some of the key things were about actually bringing in the different communities. One thing is making sure that, you know, it's not just the senior people who are leading it, because there are more junior people who are bringing in great ideas. Collaboration was a really big focus. So, you know, bringing in larger studies, collaborating so that you're kind of combining into larger studies, and thinking about the different skills that people can bring. But one of the things we did talk about was that when you are bringing in different communities, it's really important to learn from each other about the challenges and languages that each other use, because you are working in very different worlds. So it's really about understanding how everyone works. We also spoke a bit about kind of encouraging putting in like an overall infrastructure. So the building blocks, making sure particularly that vulnerable groups and seldom heard groups, which are often hidden in our routine data sets, are kind of addressed. And we spoke a little bit about actually how can we do this, how do we use innovative methods to do this, and do we actually need some focused work on this, like an additional work stream, for example, to kind of address this. And just my kind of final point, but I give everyone else a chance to talk as well, is just being really transparent about recording what people are doing, because then that can help with the coordination, so knowing who to signpost to. We spoke a little bit about building on the process of the existing HDR UK funnel and prioritization process, and just kind of mapping that whole process so that everyone is clear on what can and can't be done.
Thanks, Andija. David Seymour, do you want to do yours?
I will give it my best go. So thanks to the group again for some very, very good rapid fire suggestions. So I think there's probably 4 different things I might try and pick up on. First is an overriding point around now as a chance to really build out the trust of people regarding trust and understanding really of the population at large and key stakeholders, to how we can use education awareness, capture the moment of interest, to really help people to sort of understand what is intended, what's done, and make it routine that we're sharing what's happening to people's data with them. So through as a normalized channel equivalent to a bank statement, you get your data usage report, and again that gives you then an in to how you engage people and discuss a whole range of sort of research related pieces on that. So that's a sort of big important sort of thrust around trust. What are the things in the infrastructure that we need to put in place to make that happen? How do we get to a situation where access is via trusted research environments as the default? How do we make sure that then we can obviously also be able to communicate that, but also that allows us greater consistency on the decision making around data access and how we explain that away. Third theme around sort of quality, not only quality of decision making for sort of the IG piece, but quality of the data. And how do we make sure that the sort of the poor and different quality that exists across different systems is addressed, and this becomes of greater importance through machine learning and AI tools as they develop and get traction. And then the fourth point is, in a way, the reason we need to, even greater reason why we need to build trust is because we need to also find a way in order to enable for-profit companies to come in to access the data, to deliver, you know, some sort of return for them, but more importantly, to make the most of that data for innovation purposes, to drive benefits to the NHS. But having that discussion sort of with the public at large is going to be a challenging one. And therefore, the more transparent we can be about these things, the better. Hopefully that picks everything up, but if others in the group feel like I've missed something, then do please chip in quickly.
Thanks, David. Thank you. Catherine Pollard.
Yeah, hi. So I've tried to summarize what was a diverse conversation into 3 themes. The first was about inclusivity, and actually both from a diversity perspective, making sure that we are engaging with the broadest representation, including different ethnic groups and different age groups in our discussions around data and getting them to be active participants. We talked about the fact that patients with long-term conditions are obviously normally quite educated and well informed about how their data is used and often quite strong proponents of it, but actually that as citizens who might not be actively undergoing treatment, we are more probably ignorant of it. And there's some good evidence around the level of enthusiasm generated by things like 23andMe. So how can we change the dynamic so people are engaged and perhaps contributing their own data into the kind of mix as a way of changing that kind of dynamic. The second thing was really a strong theme about balance. We've seen that we can do data linkage and data assembly and data sharing at pace with still maintaining a strong ethical focus during COVID. How can we maintain that balance going forward? Not diluting our ethical stance, but continuing to do things at pace going forward. And then the final piece was just around really strong clarity. So in order for industry, particularly multinationals, to want to operate in the UK, it becomes much more helpful if you're clear on who a data controller is, how you access them, what the governance is that you need to go through and then maintain, and what the legal basis is for sharing, and we can't continue to rely on the current set of coping notices. I think that covered everything, although my group will tell me if I've summarised wrong. So yeah, clarity, inclusivity and balance.
Lovely, thanks Catherine. And on to Jerry.
Thanks, Caroline. So I'll try and quickly summarise the key points which came out of our discussion, which could have gone on, I think, for a much longer time. So one of the things coming through was to really focus in on the specific use cases that we need to respond to pandemics with health data science. So we need to have joint language about what we're trying to do, and also to make sure it's about the doing. So far less PowerPoint. In fact, I think the phrase PowerPoint was coming through, and more code, and then look at this to work back from the questions to the data to the analytics. We need to have an honest retrospective on what's gone on. So we need to look at a ruthless focus on delivery. So a culture of show the thing and a no faults frame of mind. So look back on what's come out this time, look back on what worked, what was delivered and what wasn't delivered. Where have we spent money? Where did it go? What did it deliver? So a really frank retrospective that then informs us for the future and helps us unlock the blockers. So where have there been monopolies around data and around tasks and resource? So make sure we understand what we really learn. Think about how we get the whole of the UK to work together around this. How do we switch? The comment was made that Sweden has a single ID number. The UK doesn't work quite so smoothly. England doesn't always talk to itself, but we are somewhat bigger than countries like Sweden, but that actually provides us with both a responsibility and an opportunity. So we need to think that through. We need to look at how we demonstrate impact. There was discussion around the comprehensive spending review, but we need, instead of building that out from a perspective of PowerPoint, look at the impact we could derive. So again, the code talks perspective, we could then be in a much better position in 5 years' time. Comment was made that actually we also need to look at the other pandemics happening in the background, the issues around obesity, the issues around mental health. So we bring the same sense of urgency around data to those issues that we brought to COVID-19, so that we use the lessons that we've learned to go after some of the other key priorities. And then there was just, finally, there was an observation that as we've gone through this, people have become sort of more self-facilitating. They've stepped outside of organizational boundaries. They've not felt constrained. And we've got to look at where that's been really successful and continue to encourage that cultural behavior and not sort of retreat back into our organizational boundaries and our silos. So encourage that change behavior, and that will put us in a much better position for the future.
Thanks, Jerry. I'll just summarise some of the points from our group, which were, and it's interesting how actually the conversations are quite different angles and things in there. But from our point of view, we started with the kind of this sense of having the clarity over the question and the kind of area of focus, so that you can actually have enough clarity to be able to deliver on. Then actually, and we had quite a nice example that around the kind of cystic fibrosis example that Rebecca gave, which is around almost if we can get to the point where they were starting to think through, actually, can we build from cystic fibrosis point of view a virtual hospital? Can we bring together different aspects so we can actually start having a future vision that we're all working towards, that's drawing the data towards from that point of view? So I think that clarity of the future vision that then helps us to overcome some of those barriers and obstacles on that. The aspect in terms of how we can then get to more automated, how we can get some of the things done so it's less laborious, more automated data engineering, getting the core data sets, getting some of the things just set up in a good way that we can just systematically work through them rather than being such a laborious process at the moment. Then there was an interesting aspect in terms of from Anne-Marie around actually thinking through the groups who are not engaging, who are probably where we're seeing some of the greatest inequalities, who don't want their data used, just thinking through how we're supporting those groups and are getting them engaged from there, which I think can link through some points you were making, Catherine, on yours on that. And then actually a good point, Chris, poor Chris only got about 15 seconds at the end, but in terms of around actually the trusted research environments, this kind of proliferation across the UK of effectively these trusted research environments coming up, how are we thinking through, how are we coordinating across that? Are we just creating a more chaotic system in the process of doing that? So I think some really interesting kind of points coming out of that. So if we kind of sit back from all of this, if you look at all the people who are on this call, between us all, we're a highly capable bunch who can make a huge amount happen. So it's not an accident as to who's on this call on here. It's because we think everyone can lead an enormous amount from here. If we were to say actually how we can actually, just for the remainder of this conversation, the next kind of 15 minutes or so on there, 10, 15 minutes, how do we work together as a group? I think your point, Jerry, over almost this kind of sense of making ourselves able to move beyond perhaps some of the organizational boundaries or traditional ways of looking at things, to actually we can collaborate, we can work together. Actually, we're pretty aligned on the types of things we're wanting in terms of where we're wanting to get to. This concept of delivery, of transparency, of public trust, of getting things well set up in trusted environments and so that we can actually do research at scale. How do we work together as a group going forward, and how can we make this happen? Because what I'm not hearing is technical obstacles. I'm not really hearing, actually probably it's not, I mean, there is clearly money is a big part of it, but there's an awful lot we can do with what we've got already. So just really to open to the floor is how do we make the next steps forward from here, so that actually we can really build on some of the great energy and support and collaborative activity that happened over the last few months to work as a system going forward.
David and Gary, unlock the cash.
Thank you, Chris.
So I can say one thing just to sort of kick us off, I guess. And so I think there's a bit of work to do to put our own house in order, if I'm being completely honest. So I find the data landscape relatively confused in the UK when I try and explain it to people outside of the UK, because you know, clearly we all understand what HDR UK does. We sort of understand what NHSX does, what NHSD does, what NHSE does, but I'm not sure those connections are as strong internationally as they could be. And I worry that to have a single voice, we need to really all be talking as one organization, which I realize is difficult, but I think there's a bit of work for us to do, because if we're going to effectively lobby in this space, which is what it's going to come down to doing, to change the law, etc., around data access, and to get everybody on side, we need to have that single unified voice.
Can I make a comment? I think just to slightly modify your question, Caroline, I think we need to work well with each other, but we also need to work effectively with policymakers, or at least influence policymakers, and also work effectively with patients and the public. And on those two, I think for policymakers, we need to have a better way of translating the scientific research with policy, because I think the UK really is leading in terms of the science. I'm not sure it would be widely thought to be leading in terms of the response. And then if you look at involving patients and the public, you know, if, for example, you're looking at risk groups, you need to be involving those at-risk groups in co-producing that research, and being involved in how those research questions are being set.
And Ben, how could we do that more?
Well, there's lots of I mean, I think that the charity sector and the voluntary sector has really shown itself to be very effective during COVID-19, whether that's mutual aid groups or whether that's local charities, local place-based charities, a lot of charities that fund medical research. You know, they already have their participant panels. They already have connections, very grassroots connections, and I think we probably need a better connection with those.
Okay, that's interesting. Rebecca, what are your thoughts on that? As one of our example charity, how well connected do you feel into all of this?
So I think in terms of how we involve our beneficiaries, we're quite lucky that actually the move to everyone engaging more digitally and more virtually has made people with cystic fibrosis feel much more included and on a level playing field with all of the clinicians, data scientists, because they're very used to, unfortunately, having to dial in remotely to meetings where normally everybody sat together in a room and eating biscuits that is always hard to sit and watch when you're at home. I think we're a little bit unusual alongside a few other charities in that because we hold our own data source, it means we as a charity, and therefore hopefully people with cystic fibrosis do feel more connected into the data science landscape than perhaps some service users and patients do who associate themselves with other charities. So we are hopefully a good practice example, but we're not necessarily representative. And I think it is easier for us to engage with and communicate to our beneficiaries about digital health, health data science, because we have our own data asset that they feel like they actively donate their data to, rather than sort of without their knowledge have their data sucked up into. So it's quite a different dynamic, but I think there are some learnings from people with cystic fibrosis that could definitely be relevant to other cohorts of people, and I'm happy to share that with anyone who's interested.
Thanks, Rebecca. And our clinicians, how could we be harnessing the clinical community to help with this?
Yes, my hand was up. It is Sapie here in order to talk about that, really. I think going through some of the prioritised questions that were coming through, they were very much quite clearly driven by really important epidemiological insights and didn't often reflect the clinical questions that I and colleagues had on the ground. So I think incorporating those voices is incredibly important. And there are forums to do that through learned societies, such as the Society for Acute Medicine, the Royal College of Physicians, that would be able to help us garner those questions in a way where we can then furnish those to analysts to help with them, to help answer them. I think also it is really important that we learn that shared language that's been spoken about, how we often come from slightly different worlds, slightly different challenges, slightly competing interests in terms of what we do with data and how it can be processed and what our primary function is. And because this group is so diverse and reflects people from across the whole piece, from data providers, clinicians, right through to the analysts and the infrastructure and people that will benefit from the outcomes of that, we can maybe be a centre for that shared learning so that we voice the challenges across the piece, as opposed to reflecting just frustrations about a lack of data access sometimes.
Okay, that's interesting. Anyone from the more policy side of things as to how we could almost address some of the challenges of some of the disconnects and things on that, or how could make the research more useful, readily useful to policymakers?
So I'm happy to jump in there just for a second, Caroline, and say that we've been working with the Health Foundation for the last 3 months to bring together and convene the various stakeholders involved in improving and strengthening social care analytics. And we would very much hope to be working over the next 12 months to build up a community of practice with that in mind, to continue to bring together commissioners, providers, but also those doing the actual work with the data, as well as those in receipt of the care themselves. So we get the challenges that they want to address at the front line in terms of being our beneficiaries as a charity. But we do that in a way that actually aligns and incentivises cross-boundary working between them.
That's really helpful. Thanks, Anne-Marie.
Can I come in, Caroline? I think one of the things that, as a community, that's happened that's very different is that people have mobilised because of a need and an urgency which wasn't there before. But there are there's a need to prioritise things as kind of do this week or do this month versus things that are 6 months' time. We should pay attention to that, because our usual business as usual impact models for research aren't fit for purpose to cope with that.
Thanks. Yeah, thanks, Amy. Phil, I think you had your hand up as well.
Yeah, to pick up what Ami's just said, I think there's a danger here of jumping from the specific to the generic.
Mm-hmm.
It must be understood that the COPE notices only allow you to do COVID research, and yet you are talking about all research. Yeah, and while you might be learning ways that things work better under emergency situations, I don't think you should think that these will necessarily translate out of an emergency into a general acceptance. Yeah. In fact, I think Anne-Marie has some indication in her pollings that that's not the case in the public mind already. Yeah. And that leads to my second point, which is not necessarily policy, but the political and economic context. Beware, and we say this to every grouping that we talk to, Med Confidential, of your own narrow interest. You are working in a context that is potentially toxic. And while you pursue your interests, and they are good, noble things, and I don't doubt your intentions, you actually have to be on your guard that these things are not being used as cover by people for much broader agendas. Yeah, that's a note of caution.
So thank you. And on that, Phil, does that, from that point of view, is your thought that keep it quite tightly scoped around? Yeah.
What I like hearing here is that you're saying get the use cases. We have always said, tell us what questions you want to answer, you want answered, and then obviously you can get the data. Give us all the data as a basic request is just nuts, and that is what you will get from Number 10 and other places, and transnational trade and whatever. Everyone will just ask for all the data. If you discipline things that the way that people get data is by saying we are trying to answer these questions, then you will have a much better chance, I think, over the next period of developing strong governance and all the sorts of things that will build a trustworthy system. But if you go in on the premise that we're just trying to make value, I mean, that value used to be just money. Now it's some other thing which we haven't yet defined. Yeah, in the context of international trade deals being cut really fast after Brexit, blah 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 blah. You know that whole picture. Yeah, I just want to make sure that I raised it in this conversation, because the things that will go wrong won't be anything that you're trying to do. Yeah, it'll be the stuff that you haven't defended against.
Thank you. Thanks, Phil. Before we go, I'm going to ask David in a moment in terms of one last group. I was just going to ask from actually two last groups, so I can squeeze quickly in. I was interested to hear kind of Matt and Cecilia's kind of reflections at this point from a kind of almost how we're thinking through from the kind of genetics linking together routine data, just how your thoughts are on that and taking that from this conversation so far. And then I was going to ask Richard Talbot from an industry point of view, just to kind of finish us off on that.
Cecilia, do you want to go first?
You can, and I can hop in later.
Okay, so I think actually we're in a good point from a genetics perspective. We've kind of reached 20 years from the Human Genome Project, and we're kind of at an inflection point where there's a good international alignment about what needs to happen next, and actually some international articulation of what are the use cases for health data associated with a number of different kind of common diseases, which cumulatively have at least as big a burden as coronavirus, and we're just inured to their impact in our societies. And actually, I think there's a real opportunity and a real appetite for the research community to articulate those use cases in ways that hopefully will resonate with everyone in this conversation.
I agree with that, and it ties in with something that I think you, Chris, wrote in the chat as well, that defining use cases is a really good starting point because it will allow people to align, which I think is crucial.
Thanks.
And the genetics community has aligned, and I think we have a common sense, like Matt said, about what needs to happen next to lay a test bed for how to go about this in a serious, large-scale, comprehensive way.
But, I mean, maybe if I can spill one really quick example to show how far we have to go on some really basic stuff. On this point of linking genomic data to clinical data, at Genomics England, we have one of the world's largest collections of both human and cancer genomes for people who've had lung cancer. But we still can't get that linked to smoking status. And you would think that would just be, I should be shocked, frankly, for the fact that that's still true. But we have to sort out some of these basics before we can actually unlock all of the progress that we're talking about.
Mm-hmm. Yeah, getting the basics in place. Thanks, Chris. And Richard, from an industry point of view on...
Yeah, thanks very much, Caroline. And this has been a fascinating conversation this afternoon. And just to be really clear, I mean, I want to try and help make sure that the industry is a useful and constructive partner across all facets of the agenda that we've discussed this afternoon. And it's extremely important from an industry perspective that we get issues around good governance and appropriate use and trust right. So I'm 100% committed to that agenda. And, I think on the one hand, I would say to everyone on the call, I'm definitely happy to act as a kind of two-way conduit, if I can put it that way. On the one hand, for taking feedback around your experience of working with the industry on these issues. And on the other, I think, it's maybe helpful for the industry to be clearer about articulating what, from an industry perspective, is attractive, and certainly that plays into policy discussions in quite a powerful way at times. So I definitely welcome the dialogue on this. I would be really frank and say that I think that companies, in my experience in trying to work on these data issues in the industry for quite a few years, companies have struggled to find a home organizationally for proper strategic thinking about the potential for health data use. And frankly, the tendency at times for the issue to get siloed in R&D departments is in a little way analogous to it being siloed in parts of academia. Not that academia is necessarily a bad thing, of course, but I think what we've learned is that the unlocking the potential of health data is something that will affect every aspect of the business. Like I said in the opening kind of session, I think companies are in very, very different places as to the extent to which they get that and are acting accordingly. And this is, arguably the most important conversation we need to have in terms of how the industry evolves to innovate in a different model. But
thank you, Richard. That's really helpful. I'm just going to, our clock is ticking down very aggressively here in front of me. And so I'm going to hand over at this point to David.
I've got 33 seconds, I think, and counting. Look, I think it was Ben Golder, or someone I think at the beginning said, we can have a very interesting discussion, which we've had. And it's been really, really insightful and interesting. But so what? We've got to get some actions and some delivery coming out of it. So look at you, Caroline.
Exactly,
really.
Yes.
Look, I think for me, we're looking at 4 million people unemployed probably as a result of COVID, maybe higher than that. The consequences of that for health inequalities are going to dwarf anything that's coming out that's happened over the last sort of 3 months from COVID. And so I think, in a way, the lens we have to look at the use of data, the power of data through, and it's slightly picking up Phil's point as well, is through what can it do to help us tackle health inequalities. And I suppose I've always taken the view that this coming together of all this genomic data with the healthcare data, social care data, and other data ought to change the whole paradigm of how we have a personalized prevention and personalized treatment in the health service, which will fundamentally change the way we deliver healthcare and may enable us to sort of reverse the inverse care law, where we spend the least on those who need it the most. If we could just harness the power of data, I think it's a huge. I mean, for me, I think it's our biggest opportunity in healthcare, because the old model is broken. forget when we went into COVID in February or March, the system was already broken. Waiting lists were going out, health inequalities were rising. That system is broken. So the question really, I think, for us is how do we use the power of data and all the analytics that surround that data now to completely change the healthcare paradigm from a very late treatment model to a very early diagnosis and prevention model. I think that is really the challenge of this conversation, really. So, look, on behalf of Caroline and myself, thank you all very much for coming to this. I hope we can continue this somehow.
Yeah.
And Caroline, thank you very much for arranging it.
It's a pleasure. Thank you so much, all of you, for joining. You're a fantastic bunch. We are collectively the future leaders of all of this, so it's up to us. If it succeeds, it's because of us. If it fails, it's because of us as well. So we need to take responsibility for making things happen from here. We're going to pop a survey around so you can each tell us how you'd like to be involved going forward, and make sure we can get things moving from here. And the whole thing will be, as Ben said, around delivery, from how do we get stuff happening fast to meet the next stages of things. So thank you all so much. Take care, everyone, and see you soon. Bye.
Bye.